All right. Hey, everybody. I'm Jonathan Rasouli. I apologize for a little bit of the late start to tonight's session of Virtual Global Spine. Um, I'll preface by saying tonight's session is going to be a little bit more directed towards residents and fellows. I'm going to kind of go a little bit into the nitty gritty details of anterior and posterior cervical surgery, kind of the indications, just kind of like a general overview of the management, both surgical and non-surgical, and kind of the anatomy and this is a good time, I guess, for any residents or fellows or med students who are on or even attendings, just to ask any questions that you may have about this because I feel like many times during my training, I had all these kind of like little questions I wanted to ask, but I always felt too embarrassed to ask. So this should not be this is one of those sessions where I want you to kind of flesh out any questions you may have. So, one of the things that when it comes to degenerative cervical pathology or arthritis of the cervical spine, as I say to my patients, right? There's so many different ways it can present. It doesn't just necessarily present as radiculopathy, right? Very frequently, patients come with axial neck pain or axial neck pain with radiculopathy. They may have headaches. They may have myelopathy, right? It's such a wide spectrum of different disorders that patients may present as. Now, the majority of patients are going to come to your clinic with axial neck pain. That's like 99%. Everyone has neck pain. I have neck pain. I'm giving this presentation now and it's giving me neck pain. um, but where, where this pathology becomes more surgical is when you start including things like radiculopathy, right? We really try to avoid operating on pure neck pain without radiculopathy. And radiculopathy can present very differently. It doesn't necessarily have to be, as you see in this picture, somebody who has pain originating basically from the neck that travels all the way down to the fingers. That doesn't usually present that way. It can present with almost like shoulder pain or interscapular pain, or like kind of a vague numbness or burning in a particular distribution. And it can be frequently bilateral too. It doesn't necessarily have to be unilateral, right? But the word radiculopathy is essentially a compressive etiology as compared to radiculitis, for example, right? So you have pain that radiates from the neck due to some external compression of the cervical nerve roots, right? So with axial 100 and then just lay down a little bit, take some medicine, you'll be fine, right? Take a Tylenol and you'll be fine in the morning. 99% of it is like that, but there are people who that just doesn't help, right? And they just continue to have pain, continue. To have, but like I mentioned, for the vast majority of people, it's just a very benign and self-limiting process, right? So, you know, they've done kind of population studies on this. One of the biggest ones was a Mayo Clinic study in '94 where they looked at big population study looking at the incidence of axial neck pain, right? And what they found is that usually right around 50, 55, or I feel like this is getting much younger these days, right? Um, is right where people start having neck issues, right? And the most common presentation is a C7 ridic, usually on the side of where your dominant hand is, right? Your dominant handedness. So, let's say for me, I'm right-handed, so usually right around 50, 55. Probably start actually it's happening now as I'm as I'm in my practice, but usually the most common presentation is a C7 ridic. So usually it would be like a right C7 ridic from a right paracentral C67 disc, right? That's usually how that works. And that's very typical for that disc to be affected over time. Majority of those were asymptomatic at 5 years. So what that means is the vast majority of these patients will do just fine with conservative therapy, right? So like depending on how your clinic is run, you may frequently see patients who have not tried conservative therapy and are presenting with neck pain and radiculopathy. The first treatment is always, always conservative for these patients, right? You're not going to just rush a patient to the OR unless there's certain risk factors that you may see on their presentation or certain things on the imaging that may drive your direction to doing surgery a little bit more quickly rather than putting them through physical therapy and pain management, right? So I know hands-on kind of jobs a history of prior trauma as well too. This with female predominance, it's very, very slight. It's like 52%. So it's very slight female predominance. But it was interesting to see that a lot of patients had some remote history of being in some accident or having some sort of injury in the past, and then having chronic neck pain. And you can imagine this list just goes on and on and on and on and on of all the different causes of a neck and radicular pain, right? But what we're really going to see on an elective setting and an outpatient basis, that 80% of your patients who present to your clinic are going to have degenerative pathology, right? And degenerative pathology can present in different ways. It can present with cervical spondylosis, right, which is essentially arthritis of the cervical spine, which gives you a whole spectrum of disease. You have bulging discs, osteophytes. You have bone spurs pressing on the nerves, on the spinal cord. You have ligamentous hypertrophy. You can have kyphosis, either that's segmentally or globally. You can have, I mean, the list goes on and on and on. So rather than go through each one of these things point by point, you can kind of use this catch-all term called degenerative cervical spondylosis, which just captures everything. I found that was pretty an easier way, of just saying all the different things I mentioned before. Facet hypertrophy, calcification of the ligament, I mean, it just goes on and on. So you can just say degenerative cervical spondylosis, right? Now, when I was in residency, I got a little confused with the nomenclature, and still to this day, I still get a little bit confused in nomenclature. So, what was the difference between spondylosis, spondylolysis, spondylolisthesis, and spondylitis, right? So it's like, cervical spondylitis, right? It's not really the right term. So cervical spondylosis, losis, is degenerative pathology, arthritis, developmental pathology. Okay, so you're looking at all these things that affect all the different parts of the cervical spine. As you get older, and with certain conditions, with let's say smoking, lifestyle changes, this can accelerate arthritic or age-related changes in the spine or developmental changes in the spine, and that's what we call spondylosis, right? Now, what happened here? Sorry. Okay, so when we evaluate these patients in clinic, right, we look at all kinds of things. I'm not going to go through this, but this is basically looking at, what are the red flags? When someone comes in, they say, yeah, I have neck pain and my arm hurts and I have numbness, right? Everybody has that. So you get, you wonder, okay, who are the patients who can go through pain management and physical therapy and I can operate on them in a couple of months, or who are the patients I need to send to the emergency room right now, right? And they probably need surgery like tonight, or they need surgery maybe like first thing tomorrow morning, right? How do you triage that? That takes time. It takes a lot of time. It takes a lot of experience. But in general, anything that's been present for more than a week or two is usually can wait a little bit. Anything that happened today or a couple hours ago it usually has to go to the OR. Um, so with the spectrum of presentations where you have axial neck pain, radiculopathy, and myelopathy, that's generally the three ways this is going to present, right? And there's a lot of, it's very rarely just pure, right? It's usually a spectrum of this. They have axial neck pain with radiculopathy, axial neck pain with myelopathy, myelopathy without neck pain, right? Radiculomyelitis. I mean, you have so many different things, right? And based on this, it helps triage where these patients should go in kind of a treatment algorithm. Okay. I'd say the key thing, and also ultimately the choice of procedure for these patients if you're going to operate on them, right? Either going anterior or posterior. And there's differences between these. Now, myelopathy exists when there's spinal cord compression or sickness of the spinal cord, right? and that can be from 100 different things. Now, these patients present with numb, clumsy hands and difficulty walking. That's the classic presentation of cervical myelopathy. Okay, numb, clumsy hands and difficulty walking. And when it gets super severe, it can present also with sphincter problems, urinary issues as well, almost like a neurogenic bladder type presentation. And when it gets to that point, it's very bad. It's much less favorable natural history. The patients are less likely to do well at that point. So you try to catch myelopathy relatively early before it gets so severe that the patients are really kind of debilitated by this. And there's some controversy whether, if they present to you very debilitated, does it even make sense to operate on them at that point, right? And the answer is maybe sometimes, as with anything, right? Um, so really the main things, if the patient comes, you see them for the first time and they present with, if they're presenting with weakness and they have this history of prior cancer and it's new, you should probably send them to the ER. And they have no new imaging, you should probably send them to the ER. If they have a new neurologic deficit, patient came in, this is rare, but sometimes I've seen this, a patient who comes into my office who had like stable neck pain and radiculopathy for a while, and then now, and they have older imaging, and then like a couple of days ago, they now have like they're extremely weak in their hand or something like that, and that's the kind of patient needs to go to the OR or needs to go to the ER for like immediate imaging. Patients who come in absolutely intractable pain, nothing is helpful at all. They should probably go to the ER too, because what are you really going to do at that point? They probably need some sort of IV medication, maybe some steroids. It's not much you can really do to help them in the office, right? Um, and then, of course, patients who have a history of prior drug use or ejection users who are presenting with fever, that kind of goes without saying, right? Um, so in terms of the anatomy, right? Remember, the cervical nerve roots, they start off going above the corresponding pedicle, right? So C1 nerve is above the C1 pedicle, C2 is above the C2 pedicle, and as you kind of progress downwards, right, it all of a sudden switches, right? The C8 nerve root is above T1, and then T1 nerve root is below the T1 pedicle, right? So that's where that transition point occurs, is right around C7 T1. Okay. Now, when I was starting to look at imaging, all I really cared about was X-ray, the lateral X-ray and the sagittal MRI and the axial MRI. But now I really take a lot of time looking at the AP image as well too. Um, and that's happened in the past year or so. And the reason why is if you look at the AP view of the cervical spine, which I have here, this is just I took this picture from the Benzel textbook, which is really excellent, by the way. It's very dense and it's very big. It's called the I think it's textbook of spine surgery. It's really great. Benzel and Steinmetz. I would suggest you kind of get this during your residency and training and use this as a reference guide because it can be really helpful, especially with the pictures. So this is a picture on the left of a normal cervical spine with minimal degenerative problems, and the one on the right is like a totally like burnt out cervical spine, tons of arthritis, right? And the main thing I'm looking at, why I like the AP view, is the uncovertebral joint, right? And that's really what I look at. So you can see that under normal circumstances, you have the uncus and the uncovertebral process, right? And it really shouldn't really fuse too much with the superior or the inferior end plate of the superior vertebra. Does that make sense? So the superior vertebra, inferior end plate of the superior vertebra should be kind of some space between them because there's a disc here. But as things kind of settle down, they break down over time, these confuse. And this is what the majority of the compression usually comes from, is from the joint elution. No one really calls it that. We just call it the uncovertebral joint. So this joint now, this fusion of these two is what is the majority of, is where the pain comes from. And the majority of the compression on the nerve root that's exiting at this level. So when you're doing a ACDF, for example, you really have to make sure you come out laterally to decompress this. Otherwise, if you leave a lot of the uncovertebral joint behind, they're gonna have a lot of pain. So you have a lot of failed ACDFs, and these are the hardest to fix because how you really cannot actually you decompress that uncovertebral joint. anatomy. What I always the neuroforamen. Um, the super because that helped me when I was in residency because you're looking very frequently looking at things through a microscope. It's all coned in, and frankly, I never knew what I was looking at. Like, I never wanted to admit that to my attending, but but like I would look in there and I never understood what we're looking at. It was disorienting. You see this little thing, you don't even know what's going on. So it took me a while to kind of really understand where things were and where I was like where we were using the kerosene and things like that. It made much more sense once I kind of learned this. So the neuropramina, right? The superior and inferior boundaries are what, right? They're the pedicle. So the above and below the neuropramina is the nerve, right? So above it and below it is the pedicle above and below, right? So you kind of don't want to get into that. Not much you can really do with that, right? So anterior and posterior to the neuropramina is what you can actually deal with, is what I call it. So the uncovertebral joint or the Luschka joint is anterior, okay? Because that's formed at the intervertebral disc level. Does that make sense? So that's what you can when you take out the disc, as you go laterally on an ACDF, you're eventually going to get into the uncovertebral joint. And that's what you really need to decompress because that's the anterior border of the neuroforamina. Because not much you can really do is superior and inferior, right? And in posterior, the nerve is in your way. So you can't really do much. So you really have to make sure that you're decompressing anteriorly. That's where you get a lot of the good relieving a lot of that nerve root compression is anteriorly. So this is called the Sperling maneuver. I do this to my patients. It is a little bit painful, but um, it's very specific to compressive etiology on the nerve roots. And that alone is can if you elicit a Sperling sign, it's almost 100% chance that they're going to have some sort of like clinically significant compression, nerve root compression on the MRI. So, like, if you have a positive Sperlings, they're usually surgical. Usually surgical. Um, as I mentioned, it's usually clinical spectrum, right? Some of the things you have to look for, and I can't tell you how many times I find this in my practice, is patients who have what I call orthopedic problems, who come in with complaining of spinal issues. They're referred by their primary care because they have like this vague shoulder pain or interscapular pain and weakness, and they get an MRI of the cervical spine. They see some stuff, some degenerative stuff, and they send them over to us. But in reality, it's actually a rotator cuff issue. You know, I can't tell how many times I see that. It's very, very frequent. One of the best things is a Faber maneuver that really is very sensitive and specific for rotator cuff injury, or having them outstretch your hands. Like imagine they're holding a pizza pie and then press down on their hands, and if that elicits pain in the shoulder, it's very sensitive and specific for rotator cuff injuries. So you also want to check for Hoffman sign, right? That's the kind of a hyperreflexic, a sign of hyperreflexia in the hands. Um, and as I mentioned, the Sperling sign as well too. So just depending on the pattern of compression, you're going to see different types of pain. Now, one thing that's interesting is and I should mention is the C4 nerve. Okay, C4, so that would be like a C3-4 disc. A C3-4 disc can present as axial neck pain. Okay, so C3-4 disc can actually cause axial neck pain. So if you see somebody with a C3-4 disc and they're presenting with axial neck pain, that is something that could be the cause of it. Not all the time, but it could be the cause of it. Just remember. Now, some of the weirder things here that I remember actually with Virtual Global Spine and a presentation Dan Rue gave was weird presentations of cervical radiculopathy, which I would recommend all of you watch. It's a very interesting talk. But a C2-3 disc can present as eye pain, which I thought was really interesting. This retro or the occipital headaches or eye pain. I see these sometimes in some of my older patients who have these C2-3 discs, which happens to be the case in older patients. They can present with eye pain, and that can be due to that. Imaging, we know about this. Now, some of the signs of spondylosis, you have major facet hypertrophy here, just totally degenerative and burned out. You can see things like, here you have a right fresh paracentral disc causing nerve root compression. Here you can see signs of just, desiccation of the disc spaces with dynamic instability at 3, 4. There's, you can see that how inflection, there's there's like subluxation of C3 on C4, and when it reduces when the patient's in extension, right? You can see signs of cervical kyphosis as well too. Spondylosis at 4, 5. I mean, you can just nitpick every little thing. There's fusion of this facet joint here, this kyphosis, right? Now, one of the things I wondered about, and like, look at, are all curves equal, right? Is the A curve different from the B curve, right? Where the apex of the kyphosis is different from the C curve, which is probably the most common, right? And the answer is, yeah, a little bit. If there, how does, when patients who have cervical kyphosis and you get a flexion extension MRI or flexion extension X-ray on them, is there a difference in a clinical presentation? Is A worse than C or is B worse than A? And the answer is, it's a nice paper, by the way. The answer is, it depends where the apex of the curve is, right? In the C-type curve, where the apex is higher up, okay, it was worse as compared to the S-type curve, right? Where there was more of a lower apex lower apex. So it just depends on where the instantaneous axis of rotation is and where the center of the center of gravity was, or I'm sorry, not center of gravity, the center of the apex of the deformity was. So it actually can matter. So in patients who come in with like a fresh disc like this versus a patient who comes in with a very spondylotic disc, you see, look at this. So you see a patient who has like a disc space height, they have preserved disc space height with a fresh disc herniation posteriorly, versus a patient comes in with like, the classic C5-6, C6-7, two burnt out discs that are causing, some sort of compressive radiculopathy, right? Well, what's the difference? So, this is this happened much more recent versus this has been there for chronic long time. This kind of patient tends to respond, if this kind of patient tends to respond less to PT pain management versus this patient who has a fresher disc, newer pathology, versus this patient who's had this, burnt out discs for many, many, many years. They tend not to do as well with PT pain management versus the previous one I showed you. This is another example. And again, why I like the AP X-rays, right? Because you can actually look and see where the uncovertebral joint is and how much you have to decompress. And these oblique views can be very helpful as well too. So I'm going to go back to that, by the way, with the fresh disc versus the really degenerative discs. So when we look at this, sometimes all you need is a plain film to like diagnose cervical spondylosis. You can see on the left, this is like a perfect X-ray, right? I look on the right, it's like there's kyphosis, there's loss of disc space height, there's disc osteophytes, there's the list goes on and on and on. And one of the things that we can do to look at cervical spondylosis on a plain film, I remember my attendings would ask me this, is you look at certain things. So you look at the lines, the cervical lines, the anterior longitudinal ligament, ALL line, PLL line, spinal laminar, and the spinous process line. I remember I used to look at these in the trauma films. And one of the things we can look at are torg ratios or spinal laminar lateral mass distance. My attendings used to love this one, the spinal laminar lateral mass distance, or let me show you. You're looking at this. Wait, hold on. This is important because I like to ask my residents this too. Yeah, here we go. You're looking at this distance right here. Okay. This distance right here. Okay. So look at that and then look at this. You see that? You see that? The spinal laminar lateral mass distance line. If you see it less than 2 millimeters, which is it's just super compressed, 100%, if you get an MRI on these patients, they're going to have really, really bad stenosis, right? As compared to this patient over here. So I always kind of looked at that. And also with a cervical laminoplasty, that's what you look at to see if you got a good decompression, is that spinal laminar lateral mass distance on an X, when you look at the final X-ray and the attending, oh yeah, it looks great. We got a great decompression, right? That's what you're looking at, the spinal laminar lateral mass distance. I find that to be the most useful on a X-ray. There's a nice paper um, at a HSS came out several years ago, looking at specifically looking at the C5 lateral mass to canal diameter ratio. You look at this here. This is a nice paper. Maybe come look at this presentation, pull this up later on, and read this paper. It was nice. This is just a little bit more sensitive than the spinal laminar lateral mass distance. And they did all the kind of the looking at the statistics on it to see that it actually is very sensitive and specific for cervical stenosis. But in this day and age, we just get MRI, so you don't really need that. But it's helpful. It's nice. Sometimes you just all you need is an X-ray. That's all the patient comes in with is an X-ray, and then you're ordering the MRI. So it's not you can just look at it and kind of can eyeball it and be like, oh yeah, he definitely has something going on. Versus nah, this one's gonna be fine. So acute versus chronic, I'm gonna skip this. But you know, controversially, if you send these patients for PT pain management, I get a lot of questions about, do I recommend cervical steroid injections, caudal versus transforaminal? Do I like them? I don't personally. There's the risk reward is not the same as lumbar. And unless the patient is just absolutely 100 million% against the idea of getting surgery, or they have very minimal pathology on the MRI, I don't typically recommend this. For me, it's just PT, some preliminary pain management. That doesn't work after a couple of months or so, surgery. That's it. I don't really send them for steroid injections. Reason being, one, again, risk reward, because I've seen some really bad things happen with this. And again, it's not a permanent treatment. And then two, there was a nice paper that came out in the mid 2000s with Dr. Rue, where they looked at, this is a very interesting paper. And if you want, I can kind of text about it or tweet about it so you can read it. I really like this paper. It was very well designed. What they did is they looked at patients who they said, okay, this guy has pathology, is like, this guy's an operative candidate. I would do an ACDF on them. His, really bad stenosis at C5-6. I do like a 1-level ACDF. Okay. But they didn't. They sent these people who were surgical candidates for injections instead. Okay. And then they kind of just followed them out to see how they did over time. Okay. So these are operative people who they sent for injections, and they said, okay, let's just see how they do. And let's see what happens. And these are all pain, not myelopathy, pain. Of those 45 who they enrolled in the study, only 6 were able to avoid surgery. So, it didn't buy them maybe a year. That's it, maximum. Okay. So it didn't really buy them. It all ended up needing surgery anyway. So what did you really buy them? Just maybe a year? It doesn't make sense to me. So, especially with the risk reward, I mean, really bad things can happen with these injections. So it just doesn't make sense. So I don't really typically recommend injections for these patients. Now, surgical approaches, anterior versus posterior. Okay. What to do? Very controversial. Not too many guidelines on, anterior versus posterior, which is better. In general, pain procedure, if a patient comes in with radiculopathy and pain, it's anterior cervical discectomy, right? That's the best bang for your buck, is going to be ACDF. When you're looking more at deformity, when you're looking, and also kyphosis, you get the best correction of, let's say, like a swan neck deformity with anterior surgery. When you're looking more at deformity, when you're looking more at myelopathy, when you're looking at congenital stenosis, it's more of posterior. That's really where that comes in. So like someone with a dropped head, or like severe cervical kyphosis, patients who've had multiple revision surgeries, patient with cervical pseudo arthrosis from anterior. These are all like posterior approaches. Now, I don't want to say all radiculopathy is anterior. The posterior cervical foraminotomy is in the right patient, is one of the best procedures you can do for patients with radiculopathy. So, and that's a very, very powerful, it's really good to learn how to do this well. Posterior cervical foraminotomy, I find these are some of the best, the happiest patients if you can do this correctly. You can avoid all the anterior stuff. As I mentioned, it's, these are all the indications, but really I think of ACDF as a pain procedure. They're really, ACDF or posterior foraminotomy are like the best indications for pain. You don't really do like a posterior laminectomy infusion for a patient who comes in with like axial neck pain or radiculopathy, right? That's a rare patient. In general, these are the ACDF is like your gold standard workhorse best procedure for this, and it lasts the longest too, as compared to posterior cervical foraminotomy, right? Now the different techniques, I used to love asking this to my residents, like what's the what are the different techniques that exist, right? Because the one that we do, basically, like at this day and age, probably 100% now. I don't even think it's 99%. 100% is the Smith Robinson technique. It's the Smith Robinson exposure to the cervical spine and their technique, which is just what we do. It's the way we expose, we get down. We the way we expose to the platysma, the pretracheal fascia, the way we open that longitudinally, get down to the precervical fascia, bluntly dissect that, and then do our discectomy. We place Caspar pins, distract, do our discectomy, and put in an inner body, and dealer's choice on what that's going to be: metal, autograft, allograft, or PEEK, whatever you want it to be. Right? That's the Smith Robertson technique. Now there are other techniques that exist. The Cloward is probably the second most well known, and the other ones are far less known. And these all kind of became extinct in the 80s and 90s. No one really does Bailey and Badgley or the Simmons technique. What Cloward did was a very interesting technique. What he would do is he would take essentially a Hudson brace. Okay. I don't know if I have any pictures of it. This is a picture. Actually, what I'm showing you here is an example of the Cloward technique. He would take a Hudson brace, which is basically in neurosurgery, it's a perforator. We make burr holes in the skull with this instrument called the Hudson brace, and he would go on the side of the pathology. So if he had, let's say, a left paracentral disc, which you see right here, that image, that D is supposed to show disc herniation. He would take this thing and just make a big burr hole in the bone and the disc. That's where you see C. Take out this disc herniation, and in the hole that's left behind, he would take a piece of iliac crest called a dowel that was the same size of that hole he made, and push that in there. So so you can imagine, it worked very well, and there were very good fusion rates, but it wasn't good for deformity, right? It's not going to fix if someone has kyphosis or has deformity, which is often present with cervical disorders and degenerative disorders of the cervical spine. You're not really fixing the deformity, which really is actually probably the most important thing, is fixing the deformity, right? So positioning, this is the classic, taping the shoulders down so we can see it with the x-ray. I do this, I draw at midline, I draw at the medial border of the sternocleidomastoid. I put a shoulder roll to get a little bit of extension, not too much, just a little bit. I tape the ET tube on the contralateral side, right? Surgical exposure. I typically go opposite of the side of the pathology. So if it's a right-sided disc, I expose from the left. If it's a left-sided disc, I start from the right. And that is really just so that when I'm with the Kerrison, it's easier for me to decompress contralateral to me. Some people just always go right or always go left. And the reason to go left, the reason to go right is it's easier if you're a right-handed surgeon. Reason to go left is easier if you're a left-handed surgeon, or there's some older papers that show that it might be a decreased risk of laryngeal nerve palsy, but that's been shown not to be the case. So it's really just surgeon comfort is really the reason. You just have to be careful when you're lordosing them or you're taping the shoulders down, because you don't want to cause any iatrogenic injuries here. This is kind of like, where you can make your incision. You can plan it out based on the pathology, but I just pick a skin crease. Usually people have two, right? One superior, one inferior. So the superior skin crease is C34, C45. The inferior increase is C56, C67. That's usually, and that's works almost 99% of the time. Remember, our surgical plane is medial to the sternocleidomastoid and the carotid and IVC and vagus and longus coli, and lateral to the strap muscles, the trachea, the esophagus. So we're kind of working our way. You're starting a little bit lateral to begin with, and you're working your way medially. That's really the key. The common mistake, because remember, as surgeons, we tend to want to go coaxial to stuff. We tend to go too straight down, and then we can get lost, because then what happens is you can get lost in the neck somewhere because you're going too straight down. You're not medializing. So the key is to try to go medial, go medial. I love this photo because it's like the 3D view, right? So where your incision is marked, and you can see like these are the strap muscles. You can see the omohyoid. That's usually the first muscle you get into, and you can take it. That's again dealer's choice. Some surgeons are very adamant not to take it. I remember Todd Albert was very adamant. He never takes the omohyoid, and I've had some attendings who always take the omohyoid. I think in my practice, anything more than 3 levels, well, 3 levels and above, I'll take the omohyoid. 1 and 2, I usually try to preserve it. If it's just absolutely huge in some patients, I take it as well too. Just with the exposure, you take down the platysma. I like to do subplatysmal dissection, superiorly, inferiorly. Then I'll open up the pretracheal fascia longitudinally. Stay medial, go medial. Don't skive straight down, right? You don't want to be lateral. Once we get down to the disc, I get my handheld retractors in. I use a Kittner dissector to kind of get through the precervical fascia down to the anterior longitudinal ligament, and I use a Bovie just to kind of go over the vertebral bodies and expose over the disc. I like to localize with a clamp rather than a spinal needle because I try not to violate the disc. I know it's been drilled. I doubt it really matters, but it's just been drilled into my head that you don't want to stick a needle in a good disc. So I use a little clamp. I put that on there. I get my X-ray. Then I put my Caspar. Then I put my self-retaining retractors after I dissect under the longest. Then I put the Caspar pins. I get another X-ray, just to make sure we're at the right level, and then we start our discectomy. So let me skip through this. Now, once you get through the disc, it's just a matter of curettes and rongeurs and intradiscal dilators to get down to the posterior longitudinal ligament. And then once you're down to the posterior longitudinal ligament, I get a little nerve hook to perforate through that, and then a kerrison to get through the PLL, kind of the posterior annulus PLL down to the dura. And what's funny is you always say that you see the dura 10 times before you actually see it, and it's so true because really it can be difficult to distinguish between the posterior longitudinal ligament and the dura. And I generally try to always go through the PLL. Even on radiculopathy cases, I try to take it. It's very rare that I leave the PLL intact unless it's like calcified or sometimes it can be really hard to tell the difference. So once you have the graft, this picture showing they were taking iliac crest, but most people now are using allograft or PEEK or titanium to get that in there. And then plate, there's some good studies showing that 1 and 2 level standalones are essentially equivalent fusion rates to ACDF with a plate. Again, there's really it's kind of dealer's choice. Again, over like 3 and 4 levels, I tend to use a plate. I don't like to use standalones for these. For 3-level ACF, I'll do a single level standalone, and I'll do 2 interbodies with a 2-level plate covering it. And I've been getting fairly good results with that. Okay, I think I did actually show this. This is showing that Cloward study I was talking about, where he took this instrument called the Hudson brace, right? And then this is exactly what he would do. He would create this discectomy here, all the way down to the where the disc herniation was, and take that out. So you can see like what this post-op X-ray looks like. I thought it was pretty wild, right? You see there's this big bone dowel in there. So it's a pretty interesting, pretty interesting study. So in terms of the complications, as with anything with ACDF, you have like the minor complications, and then you have like the catastrophic, like absolute disaster complications, right? So some of the more common and not as bad complications are things like, obviously infection, bleeding. These can be very dangerous actually. But with infection, ACFs rarely get infected. If they do, you have to rule out esophageal injury. Esophageal injury is very rare and probably happens. Micro tears in the esophagus are probably much more common than we think, but they're rarely clinically meaningful. But any patient with infection after ACF, you have to assume it's esophageal tear or injury until proven otherwise. So it has to be ruled out. With bleeding, this can be venous or arterial. It can be deadly. So if they're this will present with a big gigantic hematoma in the PACU. It's never subtle. It's going to be some, the neck is gigantic like this. The patient's like crashing. So you have to get in there, open up the incision in the PACU, and just like literally you have to. I've had this complication, unfortunately. You have to use your you have to almost sometimes get your finger and pull this out because the clot is so thick that it does not you can't just like push on the neck and get it out. It's so thick, so it's very scary. But if everything is done well, the patients will usually be just fine. Um, Pseudo arthrosis is a very common problem after ACDF, especially anything more than 2 level, and this can be dealt with in certain ways. These are very rare, but or graft extrusion is rare, but subsidence is common with ACDF. It's essentially a type of pseudo arthrosis and is treated the same way. Duotomies are very rare with ACDF. These can be very difficult and almost catastrophic things to deal with if they have a big anterior pseudomeningocele. Very, very difficult to deal with. And then vertebral artery injury, which is a very is a rare but also a catastrophic complication because it can lead to brainstem stroke. It can lead to a Wallenberg syndrome. It can lead to pseudoaneurysm formation and rupture and death in a patient. So it's very, very catastrophic with the vertebral artery injury. Now, pseudoarthrosis is probably the biggest thing that we deal with after ACDF. The biggest one is smoking. It's the biggest risk factor, but other things like diabetes, obesity, being on chronic steroids, all these things can lead to pseudoarthrosis, right? And typically, the rates of pseudoarthrosis are higher with ACDF as compared to posterior, and the rates of anterior alone are the rates of pseudoarthrosis are higher than anterior posterior surgery. It's very if you do anterior and posterior, the rates of pseudoarthrosis are much lower. So plating has lead to less pseudoarthrosis in higher level surgeries, not so much with the lower levels. It's kind of equivalence with standalone versus plating. And in terms of the fusion rates, right? If you have an anterior cervical pseudoarthrosis, question, oh, should I just go back in there, take the graft out, put a new one in there? Generally, the answer is no. It tends to the fusion rates with a revision case are higher going posterior. So if you have an anterior pseudoarthrosis, it's generally better to go posterior. You're more likely to get a fusion that way. Now, how do you determine this? The best way is CAT scan. Sometimes I will, but I don't, the thing is that you're following these patients with x-rays, right? You don't always get CAT scans on them like at, 6 weeks, 3 months, 6 months, 1 year. What I like to do is I like to get I follow up x-rays. I get flexion extension x-rays. And this was a nice paper as well, looking at distraction, looking at the spinous process. You actually have to like blow this up to 150%. And you measure out the spinous process. I do this, and you look at this is very sensitive and specific for pseudoarthrosis. If you see significant distraction across this, movement greater than 1 millimeter, it generally means there's pseudoarthrosis there. Because sometimes you will see it looks like it can be misleading on CAT scan too. It will look like it's fused anteriorly because sometimes it can use peak and these weird inner bodies, and it looks like it's fused. But when they do the flexion extension, the spinous processes are just like splaying out. So you can be misled sometimes with the CAT scan. ACF, these patients do great. Some of the they do great, but the problem is really long term. That's really what the problem is. The long term, it's an adjacent segment disease, and over time, the risk just keeps increasing year after year after year. And really what we're finding is that JSegment disease is really a problem of deformity. So if you have done an ACDF in the setting of a deformity and you didn't fix the deformity, they're like almost 100% chance going to get a JSegment disease. Now, one of the best studies this is like the one that I always cite, this is like the gold standard paper, is the Hillebrand study in 99. And I would recommend you all read this. This is a great, great, great paper. And what they looked at here, this is really like, what they looked at here was a JSegment disease. And what they found, kind of in a nutshell, was, that picture I showed you of that patient who had the C5-6 and C6-7 degenerative discs, right? Sometimes you're like, well, both those discs look bad, but I think they're more symptomatic from C6-7. So I'm just going to do a 1-level ACDF at C6-7 and watch the C5-6 disc, right? So those patients, like 100% chance get a symptomatic JSegment disease, like a couple of years down the road. So in my practice, I generally treat both of those, and they kind of advocate for a little bit more aggressive treatment. rather than just like kind of leaving those discs, those degenerative discs alone and just watching. Um, Especially in the lower cervical spine, the recommendation is to treat those discs. That's typically what I do. So it's funny, when I was in residency, we did a lot of single level ACDFs. Now in my practice, I generally do a lot of 2 and 3 level ACDFs, predominantly to treat the degenerative discs. I don't like to leave degenerative discs alone, knowing that a couple of years down the road, they're almost certainly going to become symptomatic. They're going to degenerate, and they're almost certainly going to become symptomatic. So I tend to be a little bit more aggressive with that. All right. So in summary, when you think of axial neck pain, purely, generally that's generally more medical management, right? And a lot of these cases, and axial neck pain with cervical ridic, these can generally be treated medically, right? But in the presence of the proper imaging, proper clinical presentation, right, these patients do very well with surgery. They do great with surgery. Now, with patients with myelopathy, on the other hand, that's a much more surgical disorder. Mild symptoms can sometimes be treated with structured physical therapy, but moderate and severe symptoms generally do much better with surgery. So those are more surgical disorders. And in terms of pseudo arthrosis, JSegment disease, those are like the big subsidence. Those are the biggest things we're going to deal with, other than the bleeding, infection, vertebral artery injury, esophageal injury. Assuming the patients get through the immediate complications or risks, the biggest things we deal with then is like pseudo arthrosis and deformity and subsidence. And those is that treating those is a topic of a whole different lecture. But those are things that if you went anterior for, usually going posterior then is going to be the best bet. All right. So I know we're finishing just on time, but I started a little bit late. So I just want to see if there are any questions. If you have any questions, you can put them in the chat. If not, that's okay too. And I'm sorry for going kind of fast. I just wanted to finish on time. I threw a lot at you guys. Okay. No problem. If, you can also email me or text me on Twitter if you have any questions. Otherwise, I guess we'll stop here. I thank you all for coming tonight for the next session of Virtual Global Spine. My apologies for starting a little bit late, and I hope to see you guys for the next presentation. Thank you so much.